So next disease we will discuss is anthrax. Anthrax is caused by Bacillus anthracis. It is one of the biggest pathogenic for human bacteria. It belongs to separate species Bacillus. We have actually again several species. One already discussed, Bacillus cereus, causing food poisoning, and of course the major agent of that genus is Bacillus anthracis. It is gram-positive bacteria which is non-motile, have capsule, facultative anaerobic by type of respiration. It is big and easy to identify rod-shaped bacteria with square ends arranged in chains, and if you will apply any spore staining technique, bacteria producing central oval spores, which is one of the main factors of pathogenicity of that bacteria. Bacteria was identified, of course, as the largest bacteria. It was identified one of the first in history, described in 1976 by Robert Koch, and was studied initially by that scientist. It is first confirmed human pathogen, and by different experiments it was shown that actually bacteria is responsible for disease, not only some unidentified reason or human reason. And nowadays Bacillus anthracis is one of the most potent microbes to use as a biological warfare, and it belongs to biosafety level 2. Only few laboratories have permission to deal with that bacteria because of high contagious properties and very high mortality rate. So spores produced by bacteria are extremely resistant to environments, and again we had several cases when some graveyard of animals from Soviet Union graved in some 1980s was identified, and nowadays and constructive workers dug up dead corpse of animals, inhaled spores and became infected with pneumonic anthrax and died. So spores can survive for decades and resistant to multiple environmental conditions. First of all, cultural properties of bacteria. For cultivation of Bacillus anthracis, you can use simple blood agar. In that case, you will have very unique appearance of the colonies. They are different colors of white, non-hemolytic, but have rough texture, which is described as a ground glass or made glass. If you take a look through that agar on some source of light, colonies appear as a medusa head. Not transparent center, very dense center with bright peripheries, looking like you took a medusa and looking on the head of that medusa through the head on some source of light. We have selective culture medium for Bacillus anthracis, which is known as a plat medium. It contains several agents to inhibit growth of other bacteria, and usually only Bacillus is able to survive on that culture medium. And we have unique type of test, liquefying of gelatin stub, where inoculation in the center of gelatin stub after inoculation, incubation 37 degrees Celsius, will give unique appearance as reversed filtry strip in the gel. After inoculation of the loop will have another density. Liquefied gelatin will give you some unique 3D-dimensional structure of that filtry. If we will discuss pathogenic properties of Bacillus anthracis, then we have three main factors of virulence or factors of pathogenicity. Again, it is a capsule which helps to survive in our organism, resist immune response, inhibit phagocytosis. Loss of capsule in different experiments led to loss of virulence of bacteria, and certain strain of Bacillus anthracis is known as the vaccine strain. It is acapsular type of Bacillus anthracis, will have no pathogenic properties and cannot cause a disease, but still producing very serious immune response. We have spores, which again I mentioned, and acting as the type of transmission of the disease or way of transmission of the disease by air or by ingestion, by inhalation. And we have anthrax toxin, which actually is a combination of 3 different factors, but anyway it should be recognized as a separate toxin. Again, 3 different factors which have no activity by themselves, but in combinations they can form 2 main types of toxin. So edema factor, or EF, or factor 1, it is active molecule of the toxin, or A part of the toxin. Again, it is a biological toxin that have common structure. It should have B binding subunit and A active subunit. So in the case of anthrax toxin, edema factor is A subunit active. It is responsible for effect on CMP, intracellular CMP, leading to exchange of water, disruption of water exchange, causing edema, and clinical manifestation of that toxin activity is serious edema in the site of inoculation, and name is given because of that symptom. We have lethal factor, or factor 3, or LF. It is very poor studied molecule because difficult to understand mode of activity. But again, inside human cells, it leading to cell death, destruction, and necrosis of cells. Again, in clinical presentations, and leads to formation of unique symptom as a blackened ulcer or eschar. And mode of activity again is poorly studied. By loss of that lethal factor led to formation of aviral strains which cannot cause lethal outcomes. Of course, disease is still possible, and maybe that strain was used by Pasteur to form vaccine against anthrax. It's not really possible to identify nowadays because no confirmation is kept. But anyway, and factor 2, second factor, protective antigen, or PA, it is actually B subunit of the toxin. It is responsible for recognition of human cells and bind to receptor of targeted cell and make an entry for edema factor or lethal factor of the toxin. So different strains of Bacillus anthracis can have first and second factor, or second and third, and they will form edema toxin. Factor 1 plus factor 2 will make edema toxin. Factor 2 plus factor 3 will let lethal toxin. And if all 3 components are present in one bacteria, then it will make anthrax toxin. The most potent and the most dangerous strains of Bacillus anthracis, of course, contain all 3 factors. But it is possible to have only 1 or 2 toxins in one strain, and severity of the disease and outcome will depend on presence or absence of lethal toxin. So in clinical presentations, again, according to type of delivery of the disease, we have 3 main clinical forms. Most frequent and most popular form is a cutaneous anthrax. Again, it is zoonotic disease, so source of infection is usually some animal, herbivorous animal, domestic or wild. And we have several regions which are endemic by anthrax, and actually it's not mentioned here, but Siberia of Russia is endemic with anthrax as well. So disease is transmitted by contact with animal or tissues of animal. It can be some butchers, veterinary doctors, zookeepers, or even again constructory work, constructory activity with the soil infected with Bacillus or containing spores of Bacillus can lead to infection as well. So in the clinical presentation, that clinical form is most less dangerous and the most simple. In the place of the first contact of bacteria with the skin, initially purple, small redness and elevation of the skin will appear, which will very soon surrounded by edema and redness of the skin. In few hours, initially it will resemble a bite of the insect, but in few hours it will start growing inside, form a vesicle with the empty area with the some cavity inside filled in with transparent liquid. It will grow up to several centimeters, and then it will lead to hemorrhages, and that vesicle and liquid will not be transparent anymore. It will contain some blood portions, and very soon that lesion will ulcerate and form a small ulcer with the black bottom, which is called as an eschar. That eschar is painless. If you perform any examination, you will touch with some instruments, or a patient will touch itself accidentally with the purpose. The subject will feel nothing, and only area surrounding that eschar will be red and flame and will be very painful. Usually that form of the disease is self-limited, and in several months subject will recover, and of course that ulcer will dry and lead very significant scar, huge and easy to notice because it is a deep lesion with destruction of growth epithelium layer. In the case of improper treatment, or actually absence of treatment, mortality rate can be observed in 10 to 20%, but again it is the most favorable form of the disease. And treatment should be combined. It should contain antitoxic antibodies plus antibiotics, because separate activity of any of the drug is kind of low. Similar to clinical presentations, you see that it is blackened, ulcerated central zone surrounded by very bright intense edema zone. That picture resembles some coal in the flame, and initially in literature the disease is described as a Persian flame. It's looking like hot, extremely hot coal is surrounded by a zone of red plasma, and of course location of ulcer is different in different people. In Soviet Union we had several cases of anthracis when shaving devices made of natural fur of animals were infected with spores, and face of men was affected. It can be neck when people scratching neck after contact with with some animal, infected animal, and spores are inoculated in some wound or even into skin. And of course, most often it is skin of arms of palms when people touching something, some material, sample or animals with their hands. The most dangerous, similar to plague, and the most difficult to recognize in timely manner form of anthrax is pulmonary or inhalation anthrax, when disease is transmitted by dust, and it was described in some again fabrics dealt with the fur of animals. When dried hairs release spores, they were present in air, and workers of those fabrics inhaled spores reach lungs, and similar pathogenesis. Bacteria was engulfed by macrophage, delivered to regional lymph node. Regional lymph nodes were inflamed, necrotized, and due to severe necrotizing of mediastinum, people died, or because of destruction of lungs, people died. Mortality rate is lower than the case of pulmonary or inhalation plague, but still up to 90% of population infected with pulmonary anthrax will be unfortunately dead. Of course, we have only X-ray images because it's not possible to see lymph nodes, difficult to recognize. And third type of anthrax is gastrointestinal anthrax. Again, source of infection is animal, but usually it is use of improperly cooked or undercooked or even fresh meat of animal infected with the Bacillus anthracis. And the same lesions, the same damages are located in GIT. So similar problem, it is very difficult and not possible to recognize disease, to identify disease in early stages. Usually disease manifests with common symptoms such as a fever, nausea, vomiting or diarrhea, abdominal pain, and usually people of course will think about some common GI disorders such as salmonella or maybe shigella, but when severe cyanosis of skin and massive presence of blood in vomiting masses will appear, maybe doctor will think that something is wrong, but usually people with gastrointestinal anthrax will die in a few days after onset of symptoms, and doctors just will have no time for proper diagnosis and identification of the disease. So in that picture it is autopsy of dead human. You can see that intestine is necrotized as well. Hemorrhages and destruction of tissues are present. So in the case of anthrax, GIT form is the most lethal, the most dangerous, and mortality rate is very close to 100%. For any form of anthrax, it is essentially important to initiate antimicrobial treatment as soon as possible. Usually it is common penicillin, benzyl penicillin or penicillin G, which is very active against gram-positive bacteria, Bacillus anthracis included, or you can use fluoroquinolones or tetracycline for treatment if required. Again, we have specific prevention, but usually animals should be vaccinated not to become infected, not to infect human. And some professions of high risk, such as again laboratory workers or people who have very close contact with animals, veterinary doctors, butchers and other. So non-specific prevention is very important in the case of spread of disease in animals, and actually initially common measure was just digging of animals in the soil, but again very bad experience of humans showed that spores can survive in decades and it's not sufficient just to grieve the animal. It is essential to completely burn any tissue or even some sample or even clothes of patient or animal to prevent spreading of spores. And again, we had few cases in history of USSR and now Russia when that bacteria was delivered into common population. So first accident was observed in 1979 when in laboratory, in military laboratory, bacteria was accidentally released in air. Spores were released in air. 77 people became infected and 66 cases of confirmed death because of anthrax. Actually more people died, but reason of death is not confirmed, but more than 90% of people died because of inhalation of that bacteria. And again, maybe you heard that case when in beginning of millennium mail papers were delivered to several US governmental workers, and it is resulted in 11 cases of inhalation of anthrax because after opening the mail, spores were released and inhaled, and 5 people died because of that disease. And again 11 cases of cutaneous infection when spores were touched by skin. So disease is rare nowadays, but again it is the most highly possible agent of biological warfare use, and US and Russia, both countries, have that bacteria in laboratories, and it is highly possible that that bacteria will be used as the biological warfare. First of all, of course, because of production of spores. It's very easy to deliver that bacteria by any route, air or water or even food, and any case, any form of the disease, inhalational or GIT, have very high mortality rate, and of course difficult to recognize, difficult to identify. So we have, of course, extremely high number of different vaccines for animals. Mainly those vaccines are based on spores, but animals should be vaccinated in endemic areas where some cases registered or were registered. We have a limited number of vaccines for human. Usually they contain spores of Bacillus anthracis and protective antigen. Without protective antigen, toxins have no activity, and usually disease is transmitted with the help of spores. So two types of immunity is required to prevent invasion of bacteria and prevention of toxin activity. Viral strains without capsule are used to produce those vaccines. So in Russia we have live attenuated vaccine, which is prohibited in a main number of countries because it's very high risk of vaccine associated disease. But a lot of countries have that vaccine, different type of vaccine for human, and it can be easily used. But again, rate of disease is very low in community, and no one will routinely vaccinate large number of people against that disease. In the case of zoonotic infections, we have a common type of test, cutaneous test, allergic skin test to detect immunity, cell-associated or cell-mediated immunity against disease. Usually that diagnosticum, that allergen is named by the name of bacteria. So in the case of anthrax, Bacillus anthracis, that allergen is named anthraxine. It is hydrolyzed Bacillus anthracis cell for application on skin, and if subject is applied with anthraxine and redness appeared near the site of inoculation, it means that subject have immunity, and it can be used for diagnosis of human anthrax. But of course, if immunity is already present, means subject was ill. It's rarely used for common diagnosis, but it's important for retrospective diagnosis to confirm diagnosis or to evaluate immunity before vaccination. We have different schedules of vaccination. Again, I will give you some international provided by CDC. Vaccination is indicated for people older than 18 years old. It's contraindicated for kids, and again, no data in elder population, elder than 65 years of age. So usually vaccine is given for people 18 through 65 years of old. Of course, it should be some high risk of exposure. Usually it is laboratory workers or veterinary doctors, and in some countries military personnel is vaccinated because of high risk of trauma contaminated with soil, and it is a high risk of spore in soil because of high use of animal and industry and others. So in some countries military personnel should be vaccinated as well. Vaccine is given in 5 doses for pre-exposure vaccination. It is now 1, 6, 12 and 18 months after the first dose, and if it is required, then annual booster dose until needed. And if some healthy person not vaccinated before was in contact with ill or already confirmed case in animals, then 3 doses should be given. Course of course is much shorter to provide faster immunity, and doses are given today in 2 and 4 weeks after the first dose. And of course, if it is the very high risk that subject is already infected, then the proper course and very long course of antimicrobial therapy should be provided for that subject as well.